Infection Control, Introduction to Nursing Concepts. This is Martha Olson. Part 4. As we look at our CDC guidelines, Centers for Disease Control, we look at the hand washing has to be at least 10 to 15 seconds in order for those microorganisms to be loosened and removed from the skin. The more heavily soiled, it may take longer, and we also know that the soap is recommended, especially if we're working with patients that are immunocompromised. The gel is a good thing. The one exception to the gel is somebody that has C. difficile, which when you take microbiology, you'll have a great appreciation for that. And so in all cases of C. difficile, we want to make sure that we're using soap and water and not relying on the gel. The cleaning procedure for a patient that has C. diff is also different. Our 3 types of transmission-based precautions we will be practicing in our classroom and in our simulation labs as well. Airborne is transmitted by our smaller droplets that are airborne for longer periods of time. Droplet precautions are the larger droplets that are expelled 3 to 6 feet, and a surgical mask is needed for the droplet precautions. And as we look then at our contact precautions, we have the indirect and the direct. And when we look at the direct, we're looking at contaminated body fluids, and indirect is, an instrument or something that may touch them as well. We know things like chickenpox has multiple routes of transmission, so we have to use additional transmission-based precautions besides just standard precautions for them. So you would always want to go back to the CDC website to get your latest and most up-to-date information for this, because if you work in a facility where they're not always keeping up with that, you will want to make sure that that becomes part of routine of what you do. With tuberculosis, we will be having several questions on that because it is making a comeback, and we can't just pretend like it doesn't exist anymore. We know that a patient with tuberculosis would have a special room, and we call it a negative airflow room, and that's because when they open the door, the air, we would not want that air to be able to come out into the hall and contaminate, patients or visitors, people in the hall. So there's a special airflow system that pulls that air out into the environment where it's distributed outside. With the patient, as a nurse, I would wear a very special high filtration respirator mask. It used to be an N95 respirator mask, but we are seeing some of the hospitals in this area go to more of a HEPA filter, and that HEPA filter then is more of like a spacesuit where they put this on, they've got a battery pack on them, and it is circulating the air, and they are not breathing the air from that patient's room when they are in there giving care. This is also the reason that we have to be, have the MAN2 test every year to check to make sure we do not have tuberculosis as a healthcare provider. The big thing with the respirator is that it has to have a very tight seal and a filter at a higher rate than any regular surgical mask. So it's a very expensive type of patient to have in your facility because of all the precautions that we have to take. Caring for a client on isolation, the isolation room oftentimes will contain a special, what we call an ante room. Ante means before, and so off of the patient floor, then we have this ante room where there's a sink and there's a place to put the gown and gloves and mask and shoe covers on, and then from there you enter into the patient's room. When we look for isolation precautions, all of our rooms today have become private rooms, but years ago most of our patient rooms were double, and 2 people shared a room. Well, then with HIPAA and the violation of confidentiality as well as infection control, it was decided that it really is in the best interest to have patients in their own room where the door can be shut and you can contain the infections a lot better. When we look at patients that have an infectious process, oftentimes they are put down one hall or one wing of the hospital, whereas your clean surgical patients maybe are placed on a different floor or in a different area. I know in one of the hospitals I work in, it used to be that the medical floor was on one floor and then the surgical patients were on the second floor, and that was for reasons like that, just to separate your patients. When we look at your patient on isolation precautions, we have to make sure that we have a sink and soap and hot running water available to them. And then what's left in there is a stethoscope, your sphygmomanometer, your thermometer. All of that is left in that room, so it's not going from patient to patient to patient, spreading what that person that's on isolation has. PPE, or personal protective equipment, would include things like your gown, your gloves, your mask, eyewear, if you need to cover your shoes. Those people that work in surgery come and put the surgical scrubs on when they get to work. They never bring germs in on their uniform. Some of your high-risk areas like burn units, some of the OB nurses have uniforms that are in the hospital, and then they will change when they get to work. There are good reasons for that, and it also doesn't take the germs out into the community as well. Because of increased attention on the prevention of your bloodborne pathogens and tuberculosis, this barrier protection is essential, and knowing when and how to put it on is also important, and we will be practicing that in class. Remember the order that the book states to put the equipment on and the order to take it off. Gloves always come off first because they are your most contaminated. So as we look at that personal protective equipment, we think of teaching families and patients how to put on gloves and masks if you have somebody visiting. We think of anticipating. You see the gal here with the eye shield. If you think a patient is going to splatter anything, you would definitely want to have a shield over your eyes so you aren't contaminated in your eyes. I had a student a couple of years ago that was down in surgery, and he wasn't even helping with the procedure. He was doing some charting off a ways, and they had kind of a bad event happen. And when the scope was taken out of this lady's rectum, she was having a colonoscopy, it kind of exploded, and on this student's face landed some of the fecal matter. And so he had to go through many, many steps of being tested, and then also in paperwork and incident reports because of that. And so even if you don't think you're going to be in the area of fire, I would say always have your personal protective equipment on just in case. The order we put it on is the gown, the mask, the goggles, and then the gloves, and then we pull the cuff over the gown cuff so that we are protected at the wrist area. The removal of the PPE then is the gloves, and then you would go up to untie the mask string and hold the strings while untying the bottom to remove the mask. Gown goes off inside out so that the part that was on the outside that would be the most contaminated then is rolled to the inside. And then the eyewear, which is usually the least contaminated, goes off last. Some examples of things that are not PPE. Wearing that tied over your head probably is not going to protect, as well as putting, I don't know if that's sandpaper or a paper bag over your face. That also is not considered personal protective equipment. I like the dog. He's cute, but he's not very well covered in the backside, is he? And neither is this young man, who seems to have a plastic bag over his face to protect him from the particles of whatever he's doing. I don't know. Usually you don't breathe well over plastic bags, so I don't recommend that. As we look at some critical thinking, our patient with MRSA is on contact precautions. You prepare to provide colostomy care to this client. What would you put on? And as we think about it, the third one, the gloves, the goggles, and the gown to protect us from any possible splatter from that colostomy. Client with a wound infection, admitted with soiled wet dressing. His temperature is 100.6, pulse 90, respirations 20, blood pressure is 136/70. Which of the following is your priority? In looking at the answers, changing that wound dressing is going to be important. As we look in the stem of that question, soiled wet dressing should stick out to you, and we want to make sure that we take away that source of infection, because warm and moist grow bacteria, and we don't want that against that wound that's trying to heal. In looking at the nurse that is helping a physician for a sterile field, the tray must be maintained at all times. During this process, the nurse would... The answer is the last one. Put on sterile gloves to move the content of the tray. The first one, you can see the word reaching across. Definitely not wanting to reach across a sterile field. We wouldn't wear clean gloves because they would have to be sterile, and we would never let it stand for a period of 20 minutes covered with a towel because it is going to be contaminated with that. In looking at getting a patient from one place to another, usually it's down to x-ray. If they are on isolation, we have to think about the person transporting them, the patient that's being transported, the patients in the hall where they're being transported to. So it takes a little bit of logistics to get everything arranged to take a patient to another unit for a test. We would want to put a clean gown on the patient. We would put a clean gown over as a robe and then probably a blanket over the top. So they're leaving with, a clean robe, clean blankets over the top. I would put a surgical mask on that patient. And then the personnel transporting the client should also wear a barrier protection as needed and call the unit ahead that you're taking this patient to so they can prepare what they need to on their end. In looking at latex allergies, we know that some people have latex allergies, and many of our facilities have gone to latex-free so that if there is an allergy, should not be a concern. Symptoms can be from very mild, itchy, rashy, like a dermatitis, to an anaphylactic reaction, and we have to be prepared to treat the worst and hope for the best. Clients and healthcare workers can become sensitized to the latex by repeated contact or by inhaling aerosolized latex allergens contained in the glove powder. So before we would apply the latex gloves, we would want to assess for that and avoid that at all possible. To avoid becoming sensitized for that, then, they say that try to wear the powder-free gloves. Wear gloves that are appropriate for the task. Wash with a soap that's pH balanced after removing the gloves, and then don't put on the Bath and Body hand care products. We always, in the facility that we're working in, want to use a non-oil-based product. Oil-based breaks down the latex allergens, and that's where the problem comes in for that. If a reaction or a dermatitis occurs, make sure it's reported to employee health and get medical treatment if it's more than just a very minor dermatitis, because sometimes the patients react very severely, staff reacts very severely to the latex gloves. When we look at our transmission-based precautions, we look at what are our care items, and many of them have gone to the throwaway, the disposable. Even the wash rags, we very seldom use wash rags. Most of them are the bath packs today. When we carry the bedding and the dirty linens, we need to make sure that they are not on our clothes or getting near our clothes and contaminating us. We don't want to put the linen on the floor, so usually what we do in the hospital is we take the linen bag and put it over the back of the chair. So you turn a chair around the back of the chair, then hold your linen bag open so that as you're doing your bath, changing your bed, you can just put the linens in the bag very easily. With OSHA monitoring, remember we want to have our sharps boxes in a place that they can be easily accessed. So when you're done doing an intramuscular and have a long needle and have protected that needle, but can you get to that sharps box easily? There is a Needle Stick Safety and Prevention Act of 2000, and that has really changed a lot of the products we use as far as needles and how we are protecting our healthcare workers from a needle stick, especially in the advent of HIV. There are nurses and lab techs and other healthcare professionals that are HIV positive today as a result of a needle stick. So we have to be very careful. We look at our testing yearly for TB. They highly recommend, many places are mandating the influenza shot for their employees, the measles, mumps, rubella. You guys know a lot of this because as student nurses, you have had to keep your Magnus Health updated so that it's almost as if you're an employee of the facilities that we send you to clinical in, because you're as at risk as any of the staff. In the evaluation phase of the nursing process, we need to remember, as we evaluate, is it working? What is the client's response? What are our infection rates? Are we reducing the infections we see in the hospital, especially the hospital-acquired or nosocomial infections? And that ends this portion of infection control.